I'm a boy from Saskatchewan. So I was asked by the organizers to talk about living with Fanconi syndrome and chronic kidney disease, and switching the focus temporarily from curing and treating the disease with RP103 to all the other aspects of the disease, which is pretty overwhelming. There's all sorts of things to think about, and especially when you're new to the disease or you have a new diagnosis, it's just a whole other world of chemical levels and this lab and that lab. So I'm going to walk through a bunch of things, and I hope at the end of this session, I hope that you guys will, most of you will pick up a few points that you can use in managing your diseases, your kids' diseases going forward. And some of these points I've learned from you, so some of you people know all this already. But we'll see what we can sort out, especially with the limited amount of time. So some of the questions we'll discuss is why does my children need so many supplements? What is acidosis and what does it do? Some issues about phosphate, some calcium issues, issues about blood tests. Why does my child drink so much? Potassium issues, a little bit about treatment with cysteamine, and projections or guesstimates of kidney function for your wondering about what is the future going to hold for your child. So we have to go back a little bit to basic medical school teaching. Sorry about this. So this is a cut section of a kidney, and this is a cartoon of the kidney. And the kidney is full of these little filters. The filters you are born with are all that you're ever going to have. So if filters are destroyed, they're not they're not regenerated. So that's an important point, because if there's damage to the kidney at any age, the filters that are left over can work harder, but you actually never get new filters. Each of those filters look like this in the picture. There's an area where blood flows through, and then fluid leaks into the tubules. And so this is very much like a coffee filter. This, whatever is liquid goes through the filter and gets into the urinary space. And then it's, Then it's the job of all these tubules to process the liquid that leaks out of the blood, to reabsorb things that you don't want to lose, like salt and glucose and bicarbonate and phosphate, and then concentrate the urine to get rid of any water that you need so that if you don't get dehydrated. And finally, the concentrated urine with waste products goes out. Well, in cystinosis, what happens is the glomeruli leak a little bit of protein. And it's the job of this area here, the proximal tubule, to reabsorb that protein, break it down, and give it back to the body. The proximal tubule processes tons of protein every day. And so if cysteine is being deposited as crystals, the proximal tubule is one of the first areas in the body to suffer. When the proximal tubule suffers, it can't do its job, which is to hold on to all the salts, all the phosphate, all the bicarbonate that leaks from the blood. So if the proximal tubule can't hold on to all these things, the rest of the tubule aren't built to do that. And so you leak huge amounts of bicarbonate, phosphate, sugar, amino acids, and little bits of protein. And that group was identified by someone whose last name was Fanconi, and so they call it the Fanconi syndrome. Now there's a couple of dozen diseases that can give you the Fanconi syndrome. But we teach the pediatric residents about cystinosis. So every pediatric resident is supposed to have been taught about cystinosis, because this is one of the few diseases that cause Fanconi syndrome that are treatable. So they should have, the pediatric residents should have heard about this disease. They might not have seen a case, but they should have heard about it. Now, acidosis. When we talk about acidosis, we are measuring the bicarbonate in the urine, in the blood. Now, some doctors will say bicarb, some will say bicarbonate. Some labs will measure the total CO2, which is basically the same thing. It's all just baking soda. So you have baking soda in your blood. Baking soda neutralizes the acid that your body makes in the day-to-day digestion of food and in growth. So the presence of bicarbonate neutralizes the acid your body makes. And a normal bicarbonate level is 22, and that's in America and in Canada up north. If the bicarbonate in the blood is low, there's too much acid in your child's system. So that's why we measure the bicarbonate level in these kids. Now, this is how I think about what the kidney does. The kidney is really just a bathtub. And the idea is that the bicarbonate is the fluid in here. And the fluid fills up to the top of the bathtub, and then it leaks over when you've got too much bicarbonate in your blood. The normal range should be 22 or above. So as long as that bathtub is full of fluid, the kidneys are holding onto the bicarbonate. So the bicarbonate of 22 in the blood means everything is perfect and your tissues are happy. Well, if you have cystinosis, this is your bathtub. There are holes in the kidney which cause leaking of massive amounts of bicarbonate and phosphate and fluid. And so your child loses all these things that should be being preserved by the bathtub to bathe the body in the right balance of acid and base. So you lose the bicarbonate, you're left with acid. So what happens when you have a low bicarbonate? It means the body is too acid. Well, acid damages the bones and other tissues. So probably many of you will remember that one of the most common acids we have that we know about is vinegar. And vinegar and bicarbonate balance each other out. So there's a child's elementary school science experiment where you take a bottle of vinegar and you put a hard-boiled egg or a soft-boiled egg in the vinegar. And you let it sit. And over a day or so, the egg starts bubbling and the shell gets soft. All of the calcium is dissolved out of the shell. So when your child's blood is acid, the calcium is being dissolved out of your child's bones. The same thing is true of phosphate. It's very, very similar to bicarbonate. It's leaked by the glomerulus. It's reabsorbed by the proximal tubule. Phosphate's really important for energy metabolism and formation of bone. In fact, the body basically uses this equation. It takes some phosphate, some bicarbonate, and some calcium, and that's how bone is made. Now in cystinosis, the kidney leaks too much phosphate. And because you need phosphate to stay alive, because it's important for energy, the body actually takes bone and liquefies it to release the phosphate and bicarbonate and calcium in the bloodstream to keep your child alive. So every time your child has acid in their blood, every time the bicarb is too low, that's what's going on. So this is a much better impression which I want you to take away. Every time the bicarbonate level is low, every time the phosphate level is low, your child's bones are melting. And that's rickets. Some of you might know the author of this book, Roller Skating with Rickets. This is a child with cystinosis, but that's the genesis of the rickets. So, to treat a low bicarbonate or low phosphate, we give bicarb. So, say this is a level of bicarb which is normal in your blood, 22. If you have cystinosis, your bicarb level is low at 16, it's too much acid. And so this is time here. So say we give a medication dose right there. The blood level shoots up, your body's happy, your bones are saying, ah, but you still have that waterfall going on. Your tub is still broken with leaks. And so, very quickly, the level of bicarbonate falls below the normal 22 and into the acid range. So that dose of bicarbonate only provided temporary relief to your bones. So that's why we have to give multiple doses of bicarbonate throughout the day. So you give a dose of bicarbonate, the level shoots up, the kidney leaks it. The level shoots up, the kidney leaks it, the level shoots up. But the idea is as long as the bicarb level is about 22 at the worst, then you're optimal. Well, what if we just can't get 4 doses in a day? What if, because of the child or work or I'm a single mom, what if we can only get 3 doses in a day? Well, what happens is you give a dose, the bicarb level shoots up, it's great, but then it sinks down. And so when you get past about 6 hours, you get into the acid level. And so the bone starts leaking during this period of time when the bicarb is low. You give another dose, but because it's too long between the doses, acid comes back. Give a dose, acid. So multiple times a day, your child's bones are bathed in acid. leading to poor bone health, leading to short stature. Well, why can't we just give 2 or 3 huge doses? Blast the bicarb really, really high. Oops. Blast the bicarb up really, really high, so you only have to give maybe 2 or 3 doses a day. Why can't we do that? Well, if you give very large doses down the G-tube or just orally to a child with cystinosis, and you guys probably have all done this at one time, very large doses cause gastric distress themselves. Very large doses of phosphate cause diarrhea. But even more worrisome, a sudden high level of phosphate and bicarbonate in the blood will cause the ionized calcium level to fall. So if you quickly push up your phosphate, quickly push up your bicarbonate, both of those things drop the calcium. And that can lead the child to feeling shaky, jittery, have discomfort, or even tetany. And I know some of you guys have had kids with tetany. Who's had tetany in their kids? 5, 6, 8 hands. So this is tetany. So in an older person, you get severe spasm of the hands and the toes. It's very painful. And in a child who is close to tetany, if you tap them on the cheek, the nerves are twitchy, and so they'll go like that. It's painful, and you feel miserable. And if you don't have tetany, but you're close, you feel jittery, you feel ill. So that's what happens if you overdose your kids on too much of a dose of bicarb and phosphate at any one time. Doses throughout the day. Well, since the normal kidney works 24/7, wouldn't it be great if we could just give the phosphate and the bicarb continuously? And there are a lot of patients who are on phosphate in overnight tube feeds. And that works out pretty good for a lot of patients. So they get it mixed in with their formula, or they just get it as a continuous feed as a drip overnight. And so that phosphate level is perfect, 23, 24. But still, you know, hopefully the kid's not on 24 hours a day of tube feeds. Hopefully they're on maybe 10 hours at the most. And so during the day, you still have to give those extra doses to keep the bones out of the acid range. When do your kids get their blood test? Because the timing matters. If you give a dose at 7 and you drive to the lab at 7:30 and you measure the bicarb, that's working pretty good. You've got great numbers. But what if you measure that dose, that level, say 4 hours later? Bicarb not so good. What if you're kind of late getting to the lab and you're due for another dose? You actually might get a low bicarb level. Because they're changing so fast, you as a parent need to know what's the timing of the dose of the bicarb or the phosphate and the blood draw. Because the doctors don't think of that. Or a lot of doctors don't think of that. They just assume you're doing the same thing again and again. And you know your life changes, so you're not. Overnight feeds. I was just talking to a family last week. They run overnight tube feeds with the phosphate and the bicarb. Tubes disconnected at 7. They're in the lab at 7:30. Labs are beautiful. Have you ever tested your labs at any other times? Because the child's getting dosed with phosphate and bicarb at other times, but we don't know what's happening with those doses. Maybe they're not getting enough, and so throughout the day, the bicarbs are actually pretty low. If they're only testing it right after the overnight tube feed, they don't know what's going on throughout the day. Perhaps they're not getting enough in the daily, in the multiple doses they get throughout the day, and so those levels could actually be low. So what it means is if your kid's growing fine and your bicarb levels are good, great. But if your child isn't growing so well or is having problems with their bones, you need to start thinking about how the blood is being checked, because perhaps it's being checked not at the right time, and timing is important. So to add another burden to your already straw that broke the camel's back parents, you don't only have to worry about the timing, you have to worry about if the blood tube is full. Bicarbonate evaporates to CO2. So if the lab tech does a good job and fills up the tube, you're laughing. But if this is what your child's blood draw looks like at a small lab, and there's all this what we would call dead space, and if they don't process this like immediately, say if it goes by cab to another part of the hospital or to another center, the bicarbonate is going to evaporate and the results are going to come back low. Your doc's going to say, let's raise the bicarb dose, and your child may then get tetany. So you have to see where the tech's put in the blood. Okay. So timing, blood volume. let's turn to something more. So I think we all have our various fluid needs. And as parents of kids with cystinosis, I think you have certain fluid needs yourselves. Well, this is a picture by a famous medical illustrator, and this is probably from the 1940s, Frank Netter. And this is just an example of a baby who has polyuria. In cystinosis, the kidney is unable to concentrate the urine. Normally in you and me, when we wake up in the morning and we go to the bathroom, our urine is yellow, and it smells and it's strong. And that's because your brain sends a signal to your kidneys to concentrate the urine, to reabsorb the water, and only pee out the waste products. Well, in cystinosis, the kidney cannot get that message. And so the kidney is always peeing out large amounts of very dilute urine. Joe Jordan had a kidney transplant last week. He's doing really well. So a lot of you guys know the Jordans. His mom said, for the first time, his urine looks like apple juice, not water anymore. She was amazed when she actually saw the urine that his transplant was making. Well, when you're just putting out huge amounts of water, the child becomes incredibly thirsty. And so thirsty that they may refuse formula, they may refuse breast milk. And moms pick this up, and so the moms will often tell the doctor, you know, he's screaming all the time. He will throw away the bottle, he doesn't even want my breast, but I gave him a bottle of water and he just really sucked it back. What's wrong? And the doctors usually take multiple visits before they identify that something's going on. And the parent regularly says, I knew something was wrong. You know, you guys probably had that story. Yeah. So this is something that's obligatory. The kidney is unable to concentrate the urine, and that's what happens. So with polyuria, it can lead to damage to the kidneys itself, especially when the children are going to school. Some of the kids really don't want to go to the bathroom frequently because it identifies themselves as being different than their friends. So I've had some kids who work at holding their pee to the last possible moment and then running to the bathroom. And so because of the huge amount of fluid being produced and the pressure that they can generate, you can actually see kids developing hydronephrosis and kidney damage from holding on because they don't want to pee between classes. So it can generate a lot of psychosocial issues at school. Certainly, you want to have stock in diaper factories because of all the diapers and pull-ups and laundry the kids have to deal with. And so Indomethacin is used in some patients to try to reduce the urine output. And it's really interesting. When I started out seeing patients with cystinosis, I had just seen a couple, and then I started seeing a few more when I moved to San Diego. And then I started seeing more and more as I got involved in the research. And it's interesting how at different parts of the country, some kids are on a lot of Indomethacin and frequently, and others, their doctors want nothing to do with it. So I think you need to understand that Indomethacin, and that was mentioned by someone who asked a question earlier on, Indomethacin is controversial. Because Indomethacin itself is toxic to the glomerulus. And so long-term use of Indomethacin may actually shorten the life of the kidney, the native kidney. And when you're transplanted, we basically say you're never allowed to be on Indomethacin unless you've had surgery. But low doses for many years may make a huge difference to a person's quality of life. So this is really an individual decision that you have to make with your nephrologist. What's the benefit to your child to cut back the urine flow, which Indomethacin will do, versus the potential that it will shorten the life of your child's native kidneys and lead to an earlier need for a transplant. So you have to make that judgment. And every child is different. And a lot of nephrologists are very, very strong in what they believe. So just be aware when you're working with your nephrologist that this is kind of a religious thing, not just a scientific thing. Potassium. The potassium excretion problems are a little different than the bicarb and the phosphorus. When your child loses bicarbonate and phosphorus in the urine, they are charged. They're electrically charged negative molecules, and so they have to be excreted with sodium, which is positively charged. Otherwise, you'd develop an electrical charge and you'd actually spark. So because your sodium is being dragged out of the urine, your body's depleted of sodium, and that's why your cystinotic kids desperately crave salt. And you probably noticed that they lick salty things, they love fiery hot Doritos, they love all those things. And I tell my patients, let them eat the salty foods, which, you know, kidney specialists are never supposed to tell their kidney patients to eat salt. But they all do. And they need it because they're depleted. Well, one mechanism that the body uses to hold on to salt is farther down in the urinary in the tubules, the kidney tries to exchange the salt being lost for potassium. And that part of the kidney tubules are pretty well preserved in cystinosis patients. So what's actually happening is the kidney's trying to reclaim the potassium, the kidney's trying to reclaim the salt, and it does a swap. The kidney says you're more likely to be injured by getting dehydrated and salt depleted than you are by having low potassium. So at least for the short term, let's do this now. So that's why these kids need potassium supplements as well. But chronic potassium deficiency can cause severe muscle weakness, lack of energy, and it actually can cause kidney damage. There are studies that have shown if you put animals on a potassium deficient diet, that causes their kidneys to become damaged. So that's why we add potassium to the bicarbonate and the phosphorus that your child needs. Now with regard to cysteamine therapy, and certainly with RP103, earlier diagnosis makes a huge difference. The earlier the diagnosis is made, the less damage there is to the kidneys. And as does taking enough to maintain good white cell cysteine levels as much as humanly possible. And that's important because we're all human. In a perfect world, people would be on the right cysteamine dose or the right RP103 dose and they'd always get it. But the reality is it doesn't happen. Kids vomit, kids can't keep it down. Parents try as much as possible, but especially with the cystagon, we see lots and lots of problems. And hopefully RP103 is going to get rid of all those. But we know that families do the best they can. And then when the kids get old enough, they do the best they can to sort of avoid it if possible. So this is a battle you have to fight all the time. But this is an example of how much a difference it makes. So I'm going to show you some data. This was given to me, and I was given permission to use this. These are two sisters. This is big sister, diagnosed with cystinosis at about 1.5 years. And here, this is her growth charts. So she was way below the third percentile when she was diagnosed before her 2nd birthday. And you can see how she's made it up to about the 5th percentile. Little sister, diagnosed a few weeks of age, started on cysteamine a few weeks of age. Look at the difference in growth. So now she's 16, almost 17, and she's tall and looks perfectly normal. Good muscle, good skin. That's the difference in growth, same parents. What about the kidney function? So this is a graph that we draw regularly in our clinic for all children with kidney disease. And this is date, and this is the estimated GFR. Now this is something that a lot of you might have heard about. The GFR is the glomerular filtration rate. It's the amount of cleaning ability for toxins that your kids' kidneys do. And normal is above 100 mils per minute per 1.73 meters squared. That's why we never say that. We just say it's above 100. Dialysis and transplant is around 15. Now, in a lot of kids with chronic kidney disease, they go along, and then you start noticing in retrospect that the kidney function is starting to fail and the GFR is starting to go down, and you can actually plot a line. So you can extend that line and say, oh, this one's probably going to need dialysis and transplant that date. So that's big sister. Her kidneys were damaged by the fact that she wasn't diagnosed at birth. So even though the parents were meticulous with the cystagon, she is on her way to a kidney transplant at some point. Now, she's finished her growth spurt, so that might level out. But little sister, on cysteamine from 2 weeks of age, there's no evidence of any deterioration in that graph. She'll never need a kidney transplant. That's the difference. Good compliance, good adherence, early diagnosis, and a little bit of luck makes. Don't discount luck. If you're doing the best you can and your child's kidney function is slowly deteriorating, it may not be because of what you're doing, because there is luck involved. This is another kid. This is a kid who just had a kidney transplant shortly. There, he's about 15 years. And you could see his kidney function started deteriorating when he was about 11 or 12. And this is his serum creatinine. I plotted this. I just want to show you this. So there's a serum creatinine of 1, and that's 2005. And from 1 to 1.5, it took him like 5 years. And here from 1.5 to 2, it took him 2 years. From 2 to 3, it took him a year. From 3 to transplant, about a year. So as the creatinine starts going up, it goes up faster, faster, and faster, and that's normal. I could show you a dozen charts like this, and the line is the same. So when your child's creatinine starts going up, it will go faster and faster and faster. And as a nephrologist, I hate that. Because I think, oh, we'll do fine, we'll do fine. And then you start seeing the numbers going up. And so sometimes the parents will say, how come these creatines going up? And then we have to have the talk. And I draw this graph and I say, we can start planning. That in 3 years or in 5 years, we'll make a transplant. But not everybody is like that. This child was diagnosed at age 1.5 years. This child was able to tolerate her cysteamine really well, had iron guts, and really obsessive parents. So this child is 21, her GFR stable for the last decade, serum creatinine stable for the last decade. She may never need a transplant. If she decides to have a few children, that might stress the kidneys, we'll see what happens then. But, you know, different patients do differently. So what affects how long will the native kidneys last with cystinosis? And the number one thing is fate. How late it takes, how long it takes for your kid to be diagnosed. But also, we are built with different numbers of filters. Studies have shown that there's a variation between having about 200,000 filters and having about 2 million filters between different people. So there's like a tenfold difference. So some people are born with smaller kidneys with less numbers of filters, and other people are born with bigger kidneys. There's racial differences, there's ethnic differences, but the reality is, if your child is lucky enough to be one of those people who were born with lots and lots of filters that he or she could afford to lose some, that's a huge difference. On the other hand, if your child was born with less filters than average, then that child may have no ability to handle even a small amount of damage. So they may be going on to kidney failure. So you have to understand that it's not all within your control, no matter how good a job you're doing. Obesity. The more the kidneys are pressured to clean by the bigger the patient, the shorter that they're going to last. And so if your child is really chunky, you know, it's interesting. These kids are all scrawny until they're 2 or 3. And then some of them really start chunking out, and the parents are going, yes! And I'm saying, no! We want them skinny, we want them active, we want them jocks. Because that keeps the kidneys working as long as possible. Protein leak. Every kid who has cystinosis has a little bit of protein in their urine. But if you start seeing a real increase in the protein on the dipstick, that's a red flag that the filters are starting to smoke. Basically, when the filters that you have are working so hard that they are getting under too much stress, they start leaking protein. So when the protein leak goes up, it's basically you've got an old car, you're driving too fast, and it's starting to smoke. Now we actually have therapies, certain medications. Some people in this room, their kids are on ACE inhibitors, lisinopril, captopril, things like that. And they are designed to slow down the filtering that the kidneys are doing. And it's basically taking this car and you drop from 70 miles an hour to 50, and that car will last a lot longer. So we have therapies that we can use to delay the progress of the kidney failure. Cholesterol. The higher the cholesterol, the shorter the life of the kidney. Cigarette smoke. Obviously smoking in adults, but secondhand smoking kids, there's good data. The more cigarette smoke you're exposed to, the shorter the life of the kidneys in people who've got any kind of chronic kidney disease. No evidence that social drinking has any effect, but cigarette smoke clearly does. And there's some newer evidence coming out when people are looking at large populations of people with chronic kidney disease. Patients where the acidosis of any kind of chronic kidney disease is very well treated, their kidneys last longer. And patients who maintain too low a potassium, their kidneys last a shorter period of time. So some of these things you can control. So in summary, the book isn't written on your young children, and there are things you can control, keeping them healthy, keeping them in sports as much as possible, making sure that if you start noticing the protein leak in the urine starts going up, you ask your nephrologist, does my child need one of those drugs to protect them from proteinuria? Keeping their cholesterols under control, away from cigarette smoking, making sure that those bicarbonates and potassium stay good. Well, this is our proximal tubule with cystinosis, but this isn't going to be the way it is all the time. Because Dr. Cherqui and the group are going to give us stem cells. And like these Legos, that bathtub has been completely repaired, and in 10 years I'm hoping that I can take this little lecture and trash it. Thank you.
Thank you so much for that amazing presentation in a way that we could all understand, and I learned a lot. I'm sure everyone here did as well. Questions from the audience? Oh, one here.
You said there was an importance of timing your labs, and I might have missed your answer. Did you give us the answer when we should time it? Because we did ours at the trough, but now that I'm thinking...
If your child is healthy, not having any symptoms, and growing well, whenever you're doing it is working. If there's something that you're trying to sort out, like your child perhaps isn't growing well, the trough is probably important to check. Because if you're dipping down into that acid before each dose, you're either not getting enough or you need to dose more frequently, and you need to work that out with your nephrologist.
Well, very nice presentation. About the phosphate and carbonate supplement, if I well understood, you have to take once every 6 hours or 4 times a day. So practically, does that mean that the family will be enrolled on RP103 will have to wake up at night still?
Well, a number of the patients have switched from every 6 hours to 4 times a day. And depending on the renal function and depending on the clearance, even 3 times a day is working for many of the patients. But the important thing is to get the trough level, to figure it out.
So, Dr. Grimm, just to repeat, just to make sure we're clear on that, you're asking about the number of times a day for which particular medicine?
So I can reiterate. The idea is that we were giving cysteamine 4 times a day around the clock. And so that was when other medications were going in as well. Parents were giving phosphorus 4 times a day, bicarbonate 4 times a day. Actually every 6 hours. And that was pretty good at maintaining the numbers reasonably well. Well, now that we're going to twice a day with RP103, the quality of life is very important. And so if you can switch your bicarbonate dosing to 4 times a day, allowing the person to have 8 hours of continuous sleep, and the morning bicarbonate is still okay, and that's perfect. Some of my patients are on 3 times a day, and their morning or their trough bicarbonates are stable and they're growing, so that's good. See, the amount of leak that bathtub has is different for every patient. So some patients might really need 4 doses a day, and some might get away just fine with 3. The only way to tell is to do the tests. So if your patient, if your child doesn't have a whole lot of injury to the proximal tubule, 3 times a day may be perfect.
Just as an example, my son does his 3 times a day.
And as long as he's growing well, as long as that bicarbonate trough is good, then that's perfect.
Dr. Grimm, can Indomethacin be used as needed, say for a sleepover or on a vacation?
It works fairly quickly, in my experience, and so if you want to use it episodically, that might be a nice way to use it for special occasions, or like you said, sleepovers to try and get them drier.
How quickly? Like 24 hours? Or?
I would recommend a couple of days just to get it into the tissues. I don't know if anybody's really studied that very closely, but I wouldn't give it for more than a couple of days before the sleepover. I would look at the troughs and I would look at how your child's growing. If the growth is following the growth curves and the level done just before the dose is in the 21 or 22 range, then that's all you need. And your child is lucky that the bicarbonate wasting isn't that severe. If you find that they're dipping down into the acid level between each dose, then you have to reassess, can we fit in that 3rd dose maybe? So I think it has to be individualized based on the child's growth and based on what those trough levels are.
I'm still a little bit confused about the timing issue.
Good.
We get bloods done once a quarter,
Okay.
based on when she last had her cystinosis.
Right?
How do I know that's the right time to measure?
So what you can do in that situation is rearrange when the bicarbonate or phosphorus are being given so that you've given, so whenever you're going in to have your lab draw, like it's at 11, and you say, okay, and we're on 4 times a day medication, so I'm going to wake my child up at 4 in the morning to make sure, or 5 in the morning to make sure that it's 6 hours before the dose is due, so then you're at the trough. Or you can poke the child again. Those are different ways to go with it.
I'll tell you what, we'll put that on the parking lot, and we'll get you some specific help to get that answered, okay?
Sure.
Fair?
All right, let's thank Dr. Grimm. Thank you.